to deal with that either during or after the resection.
So I'd like to thank the association for the invitation to speak today. I have no disclosures. So the agenda or the goals of the talk really are sort of to understand the ramifications of a positive margin. It's not something that we see that frequently, but we do want to discuss what the knowledge gaps are and the complexity that surrounds, I think, why we do see positive margins. We'll review current treatment options and guidelines and also touch briefly on some future interesting directions that we may be able to employ to hopefully avoid this situation. What I will not be discussing is chest wall invasion, mediastinal invasion, or the role of frozen section in determining positive margins. I think some of those topics are covered by some of the lectures of the other presenters, and also the role of frozen section can be a little bit time-consuming and controversial. When I first got this topic to fill in for Dr. Roosh, this was my response. What? Me worry? I think a lot of us would say, oh, why am I concerned? This really never happens to me. Oh, but yeah, there was that time that permanent showed tumor in the peribronchial lymphatics. Does that really count? But it's so rare. What's the real concern? How could frozen section have missed this? That's a common thing I hear from my partners as well. But the fact is that it definitely impacts prognosis in a very significant fashion, and limited data or dedicated studies really help guide us on what our options are. But the tide is really beginning to change, and we've seen some real increases in the quality of the data coming forward to help guide us in our management of this rare situation. So when I went back and I looked at the historical context, it was really fascinating to see that authors were discussing positivity of margins as early as the 1940s and 1950s, when the birth of lobectomy and pneumonectomy was really first starting for the treatment of non-small cell lung cancer. One of the better studies from the earlier decades was from Law at the Royal Brompton, where they did a retrospective single institution study, but 1,000 patients over about a 10-year period. And they noticed that there was a 6.4% incidence of positive margins, and that in their series they had 40% of their patients with a negative margin. And what they did see was that there was even differences in what type of positive margin you could have. You could have carcinoma in situ, you could have mucosal, peribronchial, or even lymphatic. The conclusions of their study really showed that carcinoma in situ did not have a significant impact on overall survival, but peribronchial positivity was usually correlated to N1 disease. But what we didn't know from this study was what were the stage groupings that they were looking at. They looked at everybody as a conglomerate of they had surgery and they had positive margins or not. We didn't know T stage, N1 status, or whether it was an R1 or an R2 resection. Larry Kaiser and his group at Memorial in 1989 published a series looking at almost 3,000 patients. They saw a lower rate of positive margins at 1.6%. They looked really only at extramucosal positivity and only at R1 disease. The majority of their patients were actually 3A or 3B, so these were advanced stage lung cancers, and it's no surprise that they were seeing some incidence of a positive margin. What they saw was a 20% 5-year overall survival with R1 disease, with N2 disease, that is, whereas R0 patients with N2 disease had a 33% 5-year overall survival. They did note that there was a 41.7% false negative rate for frozen section, so they did not find that frozen section was that helpful in determining whether there would ultimately be a positive margin or not. Later studies from Gibrelli noted that stage 1 disease, when you had an R0 resection, did much, much better than if there was an R1 resection. Survival at 5 years went from 68% in R0 resection down to 50%, and they saw a stepwise decrease in survival from stage 2 with R0 to R1 as well. In their study, we start seeing the introduction of what adjuvant therapies do we have available to help us treat these patients, and 17 of their series, or 36%, had port therapy or postoperative radiotherapy, but they didn't see a significant effect for overall survival, likely due to small numbers. But they did see that early stage patients had improved survival with R0 disease, which really helps set the stage that what we all know, that an R0 resection is the goal of surgery. Some later studies from Germany looked at a smaller group of patients, but really looked more at port analysis. How do they do in median survival? And they show that there was really no significant difference in median survival of 14 or 6 months, whether patients got postoperative radiotherapy or not. But this study lacked a control group. The stage groupings were mixed, and 60% of the port cohort had a missed positive margin on frozen section. So I think the historical library of articles out there shows us that it's a very heterogeneous group of patients, really unclear staging. We're not sure exactly what therapy they got postoperatively, but I think the tide is beginning to change. There was a very good study from Resection that looked at over 4,000 patients, and this was published in 2010, and we really saw, I think, an increase in the quality of the literature in the late 2000s, 2010 and onward. Every single patient in this study underwent mediastinoscopy, thoracotomy, and an anatomic resection, either a segmentectomy, lobectomy, or pneumonectomy. What they found was, even with adequate staging and open surgery with anatomic resection, 216 patients out of the 4,000 had a positive margin, which is 5.4%. What they did note in a significant fashion was that T3 disease and N1 disease, so increasing T stage and obviously increasing N stage, was associated with R1 positivity. Their study included positive margins in the bronchial, mediastinal, lung, so parenchymal. This was the first study that started talking about parenchymal margins and chest wall margins. Every single patient had frozen section to examine their margins. And what they noted, and very clearly showed in a statistically significant way, was that an R0 resection provided a 46% all stage groups together overall survival at 5 years, whereas an R1 saw a 50% reduction in survival. Quite significant. What they weren't able to show was what differences in type of bronchial positivity or R1 positivity, whether that was associated with any survival difference. They were unable to show whether it mattered. What they did also show is that when adjuvant therapy was performed, there was really no difference in overall survival in the R1 patients. It was 22.4% 5-year survival in those who got adjuvant therapy versus 19.3% in those who received no additional therapy, and that was not statistically significant. Of note, no patient went back to the OR or had a re-resection at the time of original surgery, but the final conclusions from the paper really did show that R1 disease decreased survival by roughly 50%, from 46 to 20%. In their study, 74% of the patients received port or chemoradiotherapy afterwards. And for R1 patients, adjuvant therapy did not change overall survival. So what issues do we have with the literature to date? Well, I only showed 4 or 5 of the 13 to 15 series that really talks about this. The ones that I did not show you are of less quality, smaller numbers, and no significant statistical rigor. There's no analysis really by stage group, so we don't know, well, how do stage 1 patients do versus stage 1B, stage 2? Their lack of control groups or standardization in terms of what type of postoperative therapy these patients received. We don't know what port doses they received, how many fractions. In addition, we don't know anything about the anatomy of positivity. Is it carcinoma in situ? Is it mucosal, peribronchial, or is it lymphatic disease that's left behind constituting R1 disease? Most of the studies as well focused on bronchial margins and does not guide us when most of us are doing minimally invasive surgeries for peripheral lesions and maybe even doing sublobar resections. This is not the issue that we may be facing. Finally, when we also think about R0 versus positivity, a meta-analysis looked at over 1,000 patients and really showed that R2 disease left after surgery does not provide any positive overall survival advantage. And when they compared it to just exploratory surgery, when no resection was done, there was really no difference in overall survival. So this really brings us to the point of, we know that an R0 resection is the goal of what we aim to achieve. The NCCN guidelines, which we have here from the latest edition, which was formalized in 2017, states that R0 resection is the preferred treatment modality. But in those cases that we do have a positive margin, based on stage grouping, stage 1A, early stage 1B to 2A without nodal disease, or stage 3 disease, we can see that there are different recommendations on how we may treat these patients in the absence of the ability to do a reoperation to achieve an R0 resection. And most of the recommendations are for radiotherapy postoperatively in early stage disease, or a combination of chemotherapy and radiation for more advanced disease. The NCCN, like most of us, defines positive disease, residual disease as any lymph node involvement or tumor left on histological analysis. A complete resection requires a free resection margin with systematic node dissection or sampling to the highest mediastinal lymph node station, and that nodal station has to be negative as well. So a complete resection is referred to as R0, microscopic positivity is R1, and macroscopic residual tumor is R2. Really, the best data that we have now comes from large database studies done on the National Cancer Database, which represents about 70% of all lung cancer operations performed in the United States. And this really harnesses the power of large data. Now, granted, the databases are not prospectively collecting data to look at the issue of margin positivity, but it does provide, I think, in the current climate, the best evidence to date of how we should think about treating positive margins. 2 minutes. So quickly, Hancock's series from Yale really showed that stage-adjusted survival, this was the first study to look at stage-adjusted survival, showed that positivity decreased survival at all stages. You can see here that chemotherapy in a counterintuitive way actually did better than any other therapy for R1 disease and stage 1 disease, which is quite odd. You would think that radiotherapy, in fact, would have had the biggest benefit. And as we increase with stage in large numbers in these groupings, radiotherapy consistently showed no benefit to patients postoperatively. In later stage disease, the only benefit was seen with chemotherapy or chemoradiotherapy. Of note, and I think this goes to the concept of under-treatment, when you looked at this series, large numbers of patients in the advanced stage disease did not get adjuvant therapy postoperatively. So it may be that positivity of margins is also an indicator of inadequate treatment up front. Smeltzer and group performed one of the better studies looking at different stage groups and did a comparison actually as a control group using R0 resection and applied the NCCN guidelines. And they found some interesting data as well showing that port treatment for stage 1A disease, in fact, decreased survival. So there was a detriment to those patients who underwent port therapy, 26% 5-year survival versus 58, significant statistically, and as well they saw that for stage 1B and 2A patients. And chemoradiotherapy in the early stage groupings did not show any benefit at all. In later stage groups, chemotherapy or chemo-RT did show an overall survival advantage, which proved that the NCCN guidelines for later stage disease was actually adequate. So we do have some treatment options. You know, you could think about this. Well, intraoperatively, we saw the videos of what we can do to get an extended resection. But is there anything we can do pre-surgically or intraoperatively? And just quickly, when we look at some studies, we do know that induction therapy or pre-treatment can reduce the positivity of margins, although at a cost to complications postoperatively. So I think if we have a case like we've seen where we know we're going to have to do an extended resection, a sleeve lobectomy or a pneumonectomy, we do have to think wisely about which patients will get induction therapy and what type.
30 seconds.
So finally, I think some interesting studies from Japan show that there are things we can do intraoperatively. We could do a touch prep cytologic analysis in addition to frozen section to reduce the risk of positive resection margins in parenchymal cases, and in addition, aim to get a 2 centimeter margin, let's say on a 1 centimeter tumor, because that will decrease the risk of positive margins. So some future directions, we do have near-infrared technology that could help us identify where tumor is, especially helpful for sublobar resections, or even 3D reformatted reconstructions on CT imaging to help know the anatomic position of a lesion before doing a sublobar resection. So in conclusion, positive margins are rare and an understudied topic, but it does show a significantly decreased survival in all modern studies. Re-resection or reoperation to achieve R0 is the optimal treatment. large retrospective database reviews repeatedly illustrate that port therapy actually is detriment to early stage patients, and there is a benefit for appropriate chemotherapy or chemoradiotherapy for advanced disease. I think that the literature to date provides no clear answers on what the best treatment is for R1 disease, and the current national guidelines, in fact, may not be supported by recent evidence, but the topic deserves further study to optimize the care of patients with microscopic residual disease. Thank you.